Oftentimes people mix the two. You have patients say, doctor, I went through a lot last year. I had an appendix. I developed an appendix and I had to do surgery. I mean, it was so bad. Whereas what he was referring to is the condition that you develop when something goes wrong with your appendix, which is the appendicitis. So appendix is the organ. That's an organ. I'll still talk about it. Then the appendicitis is the inflammation or simply the injury when there's an injury to that organ. So commonly in the body, in medicine, we try to refer to inflammation by adding the suffix itis to organs. So when you have appendix plus itis, it becomes appendicitis. So inflammation of the appendix, like you have for the joint. Arthro refers to the joint generally. Then when you have arthro plus itis, arthritis. So that's a general principle that can guide us. So the appendix is a finger-like tubular organ. It's attached to the large intestine. So it doesn't really perform any serious function. So it's something that we can easily do away with. So that's why oftentimes in surgery, even when we finish the surgery, we don't try to complement any function like the other organs. When we take them away, we try to complement their function. But for the appendix, it's something we can do away with easily. So, like I said, I talked about the lumen, the space within. So appendicitis, the injury or the inflammation occurs when there's a blockage to that lumen or when there's an infection of the organ, the appendix itself. So when there's a blockage, and I'm going to talk about different things that can cause the blockage. When there's a blockage, what happens is that the communication is obstructed. So fluid, mucus builds up within that hollow of the appendix. It swells up. And so when it swells up, that swelling, impairs the blood flow to that organ. And of course, blood flow is what makes an organ survive. Once the blood flow to the organ is impaired, the tissue of the wall begins to die. And when they die, you can then have a rupture. So first is a blockade, then you have swelling and all of those symptoms that characterize an inflammation. Then ultimately, you could have a death. And when it dies, then the body, the muscular body begins to give way. And then you can have leakage of the content of the appendix, which already now contains pus and then bacteria. So that's what we call ruptured appendix, when the appendix bursts. So that's a complication of appendicitis. So I also talked about infection. The causes generally include bacterial infection, viral infection. Then, I mentioned the last time I was here, we talked about the worm. I mentioned parasites. The parasite can stray away from the location in the intestine and find their way into the appendix, causing an inflammation of the appendix. Talking about the substances that can obstruct the lumen of the appendix, we have fecal matter, feces. And so when the feces is hard, over time, when it's hard, it can become stony. And then it forms, that stony deposit can obstruct the lumen. You can also have undigested food substances that can also obstruct the lumen. And that's where that popular association of guava seed, that's where that comes in. So when it's true, it's a cause, it's a possibility. But let me not say it's a cause, but because the word cause makes it strong. It makes it look like the moment you chew guava seed that you're going to have appendicitis. No, but it poses you at a risk, especially when it's not chewed, very well. So the same way undigested food particles, sandy materials, and foreign bodies, even like pin, screws, and the likes, when they are swallowed and they find their way, it's a thing of chance because they may not find their way actually they may not stray off the intestine. But once they stray off and find their way into the lumen of the appendix, they obstruct it and cause an inflammation of it. The essence of all of this is to look at what to take home and some of the ways we can modify our behavior so as to not predispose ourselves to having acute appendicitis. One of the factors that contributes to the development of appendicitis is the fact that we are beginning to get more adopted to a low fiber diet. So, because if you're talking about the incidence generally, it used to be a thing of the developed nations. There used to be a wide disparity between the incidence in developed nations and Nigeria and Africa, for instance. Even right now, epidemiological studies have shown that the incidence is higher in urban settings like Lagos and all compared to rural settings. And one major factor is in the diet. Now, high fiber diet makes the food digest on time. the time that it takes for the food particles to track down, journey down the intestine is shorter. That's what we call transit time. And when it's shorter, there's no tendency for feces to slow down. When feces slow down, that's when it solidifies. It becomes tenacious, and then it can form stony substances that can then obstruct the lumen of the appendix. There's first an abdominal pain, but there's a classical presentation. There's a way classically it presents. First, the abdominal pain is vague and develops around the navel, or what you call the belly button. And so by the time you have that, over a few hours, 12 hours to 24 hours, the pain then settles at the right lower portion of the abdomen. So that's the classical presentation. But ultimately, the pain is in the right lower part of the abdomen. Then in addition, you have fever. Usually it's low grade, but can become high grade later. Maybe when there's a rupture or there's a serious systemic response to that inflammation. Then of course, as expected, you have other symptoms related to the gastrointestinal tract. Talking about vomiting or the feeling of vomiting, nausea. You could have changes in bowel habits. You could have constipation more often, more commoner than diarrhea. Then in addition, you can also have other symptoms like that suggest that the appendix is already beginning to irritate neighboring organs. For instance, if the inflamed appendix irritates the bladder based on its close proximity to the bladder, you could have frequency in urination. And then there could also be loss of appetite. That's in fact more important. Anorexia, loss of appetite. So all of these are the classical presentation, but you don't find that classical presentation, especially the migratory abdominal pain that I talked about that first starts around the navel and settles down. You don't have that in 40% of cases, and that's where the need for investigation or imaging of the abdomen, that's where it comes in. There are medical conditions in medicine like that, clinical conditions in medicine that the diagnosis is mainly clinical. So a doctor has to work with the symptoms, the complaint of the patient, the ones I've talked about, vis-a-vis the findings on examination. The examination includes palpating the abdomen to elicit tenderness, that's pain, in that region, the right lower quadrant of the abdomen. So putting this together, a doctor can raise a high suspicion of an acute appendicitis. But at times, like I said, when the presentation is not typical, you could also do investigation, including an abdominal ultrasound scan. Where CT scans are readily available, you could do a CT scan. In addition to the imaging, there's also a need to do a full blood count, a cell count, where we begin to count the number of vital cells, which we call white blood cells in the blood. So when the white blood cells are higher, it's also adding up. Then importantly, we should also draw some tests to rule out other mimics of acute appendicitis, because there are so many organs in that abdominal cavity. So, and pain may not be sufficient, so we might need to be sure there are no other. Of course, it's commoner in the young adult age group, say for 20 to 40 years. So not to say it cannot occur in children, but it's less likely in the age group of the under 5. So you find it, and it's also less common among the elderly. However, for the elderly, if it does happen, it tends to be more serious. It tends to be more complicated. So you have incidents of the rupture, the bursting of the appendix following inflammation happening commonly in that elderly group. Management is mainly by surgery, but there's room for antibiotics. But that's in a setting where you can be sure that the cause is infectious and nothing more, no complications. Then it's not as if the mechanism of the inflammation is by an obstruction of the hollow of the appendix. In that setting, there's room for first trying antibiotics. If there's anything we're going to take home from this talk, is the fact that once an acute appendicitis is suspected, there's a need to present for medical attention, urgent one, because all of these things, complications I'm going to talk about, are things that happen within 2 to 3 days. As a matter of fact, the rupture, which I alluded to earlier, the bursting of the appendix, can result following 2 to 3 days following the onset of the development of the inflammation. So you could have that rupture. Now, after the rupture, you have a leakage of the contents of the swollen and ruptured appendix leaked into the surrounding organs. First, the body might be able to contain it, and then if it's able to contain it, it doesn't spread beyond the area around the appendix. So you could have an abscess being formed. That's a pocket of pus or bacteria. But then at times you may not have that, depending on the immune response of the system, you may not have the body containing it. So you can have leakage and spread all abroad, all over the abdominal space, what we call the abdominal cavity. And so there could be spread of the infection even to neighboring organs, the spleen, the other intestine, and the likes. And that can be very severe and life-threatening. As a matter of fact, when you have that spread affecting the lining of the abdominal cavity, the abdominal space, which we call the peritoneum, we have a condition called peritonitis. Peritonitis is a very serious condition, and that can cause sepsis, where the whole body, the whole system is overwhelmed by infection, bacteria, and that is life-threatening. And when all of this sets in, the surgery gets more complicated. The treatment gets more complicated. The surgery is supposed to be a very easy one. You even hear surgeons talk about the fact that let's go yank off the appendix, joking as if it's just, you just get there and jerk it off and pull it off by jerking. That's to show how simple that surgery can be. Within a space of 1 day, 2 days, 3 days, you're back home and recovered within 2 weeks to a month. But when all of these complications are mentioned, talking about the rupture of the appendix, talking about the abscess, talking about peritonitis, the surgery gets more complex. There's a longer stay in the hospital. So the bottom line of this, the take home is that it's important we don't allow appendicitis to stay, the inflammatory process to stay enough for it to develop complication. Once you see symptoms suggesting, acute appendicitis, quickly present to the hospital, let them work you out. And if they tell you there's an acute appendicitis, there's a need to operate, let that be done on time so everything can go smoothly, no complications. You're happy, the doctors are happy.